I think this is the first time we're doing a talk on this, really important topic. So I'm glad to sort of, try it out, and we'll see how it goes. And I'll take about 25 minutes to talk about kind of introducing the idea of diversion management plan within an OBOT practice. And OBOT here stands for office-based opioid treatment. And for all intents and purposes, what I'm really talking about is a diversion management plan within an office-based setting if you're prescribing buprenorphine to a patient with opioid use disorder. I have no disclosures either currently or in the past. I want to start by providing some context. A lot of data is starting to come out in the last few years, last 3-4 years, actually looking at why people divert and why people take diverted buprenorphine and what happens to that. So I want to present that as some of the context before really jumping in some of the components of preventing diversion, really looking at sort of preventing it, monitoring for it, as well as responding for it. And over time, really thinking about how do you create a practical plan in order to minimize diversion. So those are the things we'll try to take care of over the next 20 minutes or so. So we know that, especially with all of these data waiver trainings, with more of an awareness of the opioid epidemic and more of a robust response, the number of individuals in the US who received buprenorphine as part of their SUD treatment has increased nearly 400% between 2009 and 2015. And this continues to go up. Even here in New Mexico, I know there is data from Department of Health, and there are several DOH folks here joining us, really showing that even over the last year or two, the number of providers within New Mexico who are treating over 10 patients using buprenorphine has gone up quite dramatically. And I think we're close to 190 or so providers in New Mexico currently who are treating over 10 patients with buprenorphine. So this access is improving. Still a huge gap, as I often talk about, but it is improving, but remains a major problem. And that's been reported again and again, that still, even in 2019, despite this increasing access, a majority of counties in the United States as a whole don't have a provider who's able to prescribe buprenorphine. And that's especially the case in rural and frontier counties across the country. And as buprenorphine prescribing has grown up, gotten higher, there is growing evidence that diversion and the use of non-prescribed buprenorphine is also increasing. The data varies, and again, several studies have looked at it, and all of them have shown that at least a third or even up to 55-60% of patients report at treatment entry that they had used diverted buprenorphine in the past 2 month period. So at the minimum, it seems to be about 35% or so, and on the higher range of the estimates, it's close to 60%. One of my colleagues, who's a primary care provider here in New Mexico and does in Albuquerque and does quite a bit of buprenorphine management, says that for him, it's a rarity if he sees a patient for treatment who has not tried buprenorphine off the street before. So it is quite common, and it's important for us to appreciate. So why do people do it? Studies have looked at it, and by far, the strongest association of non-prescribed buprenorphine use seems to be with insufficient access to appropriate treatment. Because treatment access is still a barrier, oftentimes people turn to street buprenorphine as a way of coping with either their withdrawal symptoms or actually as part of their own sort of recovery plan, own treatment plan, which may have some formal components as well as some informal components, including street buprenorphine. It's commonly linked to self-treatment related objectives, ranging from like full-time recovery-oriented goals, I never want to use again, to just temporary substitution for the preferred illicit opioids. And generally, and perhaps surprisingly, perhaps not, euphoria or intoxication is not the goal of patients who report having taken diverted buprenorphine. And if you look at across studies, again, study after study shows that a vast majority of people, when they take diverted buprenorphine, they're taking it to take care of withdrawals or to not go back to using illicit opioids. And it's the minority that are using it on an ongoing basis to get high or to get euphoria. And importantly, studies have looked at what happens if someone has tried street buprenorphine. And there are several studies now that all seem to show that prior non-prescribed use of buprenorphine is actually associated with improved treatment retention, right? So that's kind of interesting. that people who have tried buprenorphine off the street compared to people who haven't are actually more likely to stay in treatment. People have thought that part of it might be that prior experience, right? Expectation effect. They know buprenorphine helped them when they tried it off the street, so now they're really motivated and they're going to be more engaged in a formal treatment program. It may also be that these patients have gone through the struggles of trying to obtain street buprenorphine, kind of the hustles involved in it, and so it's almost a relief when they can go see a provider and get prescribed buprenorphine. So they actually do better in terms of staying in treatment. How do they report it? This is a study from about a year ago, that a majority of patients get the diverted buprenorphine from either a friend or a partner, significant other, or an acquaintance. You know, that dealer or stranger is about a third of patients. Most people are getting it from their social networks, from people they know. Again, same study. What is the motivation for taking diverted buprenorphine? And you can see that about 40% report they used it to manage withdrawals, and about just as many, 39%, reported that their primary motivation, the big motivation, was to self-treat opioid use disorder, right? To get high, I highlighted, in this study was about 12% of people actually use buprenorphine. I think it's simple economics. Buprenorphine is not as reinforcing, it doesn't lead to as much of a high, and it costs more, unfortunately, or however you look at it. It's pretty cheap to obtain other illicit, powerful mu agonists on the street. So I think it might be part of that if I really want to get high or seek that euphoria, I might seek out a substance that is likely to be more reinforcing and may cost less, right? And they looked at the study, again, barriers to treatment kept coming up. So they looked at barriers to treatment. And you can see that some of the major barriers that emerged included couldn't find a provider. Or if I found a provider, they had a long wait list and I just could not wait. Lack of insurance coverage also emerged as a barrier, as did the cost of seeing a provider, right? So those were some of the major barriers. This study, it's a different study, again, from about a year ago, looking at how have you ever used buprenorphine for people who had tried street buprenorphine, and you can see that 90% reported that they used it by dissolving it under the tongue, the appropriate way. And you can see that the incidence of people snorting it or swallowing it whole or injecting it or chewing it, right, is much, much lower. So if I look at this, the ways that might lead to that high, that diversion for intoxication or euphoria, might be snorting it, injecting it, or smoking it, right? And that's, again, about, smoking is quite low, and even snorting or injecting is about 1/4 of a people. And the same study found that only 3% of people said that buprenorphine was their kind of intoxicating opioid of choice. So most people reported that if they wanted to get high, there were better options out there, right? That it wasn't going to be buprenorphine. So I think it's important to point out. And 81%, so majority reported that they would actually prefer prescribed buprenorphine, but they just couldn't access it because of a variety of factors. So again, kind of really highlighting the need that we need to make treatment more accessible if we really want to address the diversion challenge, the diversion problem. Some of the qualitative responses that I thought were poignant: it's difficult to find a doc that's taking patients, or have to wait a year for a new patient appointment. A script would make the process of obtaining the drug safer and easier. There would be no illegal street deals to get the drugs, and insurance would help me to obtain it for cheaper. If it wasn't so hard to get legally, there would most likely be more people taking it and getting cleaned up than people taking drugs. These were just some of the qualitative responses that have emerged in some of the newer literature over the last year or so. So with that context, that again, many people try street buprenorphine. Diversion of buprenorphine is fairly common, especially as access has gone up, and most people are trying it really to self-treat either their withdrawals or their underlying opioid use disorder. With that context, let's look at a diversion management plan. And I broke it down into prevention, monitoring, as well as responding to it. So in terms of preventing, this is, again, kind of a little bit hard to read, I apologize. A recent study that surveyed a lot of physicians who were experienced in prescribing buprenorphine in a primary care setting, asking them, what are some things you do for diversion management? And some of the big things that come up is that majority, about 80%, assess everyone. And that's what we recommend, universal precautions. If you're prescribing buprenorphine, you should be assessing patients for diversion, right? And the second important thing was how frequently do you see the patients, especially early in treatment? And you can see that to prescribe right off the bat for a month or more is actually the minority. Most providers are starting off gently by seeing the patients weekly or bi-weekly and gradually increasing the amount of the prescription. I think another best practice. And also, urine drug screen, always testing for buprenorphine. Another best practice, I think. We definitely recommend it. That if you're going to be prescribing buprenorphine, you should have some of the kind of point of care testing available and test for it prior to prescribing it, right? So those were some of the common practices. Universal precautions. Every patient is potentially at risk. This is exactly the slide I actually use when I talk about chronic pain management with opioids. Similar idea. Treatment agreements should happen with all of our patients. Risk screening, ongoing assessment, monitoring the urine toxicology, prescription monitoring program, which is actually required by law, pill counts for those at high risk, as well as frequent visits with limited number of pills dispensed for people at high risk are all good things to put in place. In terms of diversion management. The biggest and easiest thing perhaps you can do for prevention is to use as much as possible the combination medication, the buprenorphine naloxone combination, whether it's the strip or the tablet. Strip, I think, is probably the best because you can track it by serial number, but even the tablet, the combination tablet is far preferable to the mono product, the Subutex, because the Subutex, the mono product, is about 6.5 times more likely to be diverted because it's got a higher potential for abuse and intoxication, right? So use that as much as possible. Really, the only time I use the buprenorphine only, the mono product, is pregnant women, which is the last bullet, and sometimes for people who really have a hard time affording the combination tablet and the patients that I trust, that I know well, and I can monitor closely. Sometimes I might use the mono product, but otherwise combination product is the standard of care. This is a slide looking at taking patients who are on other opioids. What happens if they inject various medications, right? And what this slide is really showing is that compared to that little blue line, the little blue bar is looking at the buprenorphine mono product. So if I had opioids in my system and I injected the buprenorphine mono product, I feel a little bit bad. I don't feel too bad. But if I inject the combination medication, which is the green bar, I feel really sick. It throws me into withdrawals, which is presumably not what I want if I'm injecting prescribed buprenorphine, right? So it makes me feel bad. So that's one reason why the combination product is less likely to be diverted. It throws me into withdrawals. And this one is looking at onset of action. How quickly, if I were to inject either buprenorphine or the combination medication, how quickly it gets, it reinforces, goes into effect, crosses the blood-brain barrier. The blue line is the mono product, and you can see it's got a quick onset of action, versus the combination product, the yellow bar, has a slower onset of action. So it's also less reinforcing. And these are two slides that I've used with permission directly from PCSS. So they're less likely to be diverted and less reinforcing. So we use the combination product. Second thing, good idea to do a treatment agreement prior to starting treatment, just like we do with all of our medications. There are actually some examples of this available for public domain. If you go to pcssnow.org, you can actually get informed consent forms available to you, as well as there are links to the sample treatment agreements that I've also included that you guys may access. In general, treatment agreements include things like being punctual, being courteous, right? Not coming in intoxicated. Don't sell, don't share your medication. Take it as prescribed, right? No early refills, safe storage of medications. Let me know if you go on any other medications so we can coordinate care, follow prescription instructions. Those are generally, in all treatment agreements, the critical components, and that's certainly the things that we have here in our UNM treatment agreement. Some other considerations in terms of prevention: check prescription drug monitoring program, the PMP, for all new patients, and then regularly thereafter. We tend to check it for every time I refill a buprenorphine prescription. The way we've set it up at our clinic is that one of our MAs or nurses who I've delegated designated as my delegate, pulls the PMP report. It's attached to the chart. I review it before I go see the patient. So if there are any aberrant behaviors that emerge, we can discuss it. And the second thing is that in general, most patients should respond to around 16 to 24 milligrams, right, of medication if you look across studies. So prescribe a therapeutic dose. Doesn't mean that some patients may not need a higher dose, but if you find that all of your patients are receiving 28 or 32 milligrams of buprenorphine, I think there is cause for concern and you should reevaluate your prescribing practices, right? Because most patients do fine with under 24 milligrams. In terms of ongoing monitoring, that's the second component of a diversion management plan. These are the things, right, that, in case there is an audit, they're going to look for. So it makes sense or helps to have like sort of policies and procedures drawn up that list how you screen, how you prevent it, how you monitor it, and how you respond to it. You can just have one policy and procedure that lists many of these things. Some of the common aberrant behaviors include positive tox screens, continuing to use opioids, or maybe that they don't have buprenorphine in their urine, right? That would be also a cause for concern. They don't come in to make appointments. They request early refills, suddenly requesting dose changes if they were previously stabilized, right? Patients who say, I'm allergic to naloxone. It can happen, but I have not seen it a whole lot. So if someone really is reporting it, the first thing I do is talk about it. It may be, and what I find most commonly, and I think this is probably the case for you as well, Clark, is that patients think they're allergic to naloxone, but really what happened is that they tried Suboxone on the street, they hadn't waited long enough, so they went into withdrawals, and now they think they're allergic to naloxone. So we talk to them, provide some education, clear up the misconception, right? So it generally was what I find. Lost prescriptions, multiple providers, forgery obviously would be a big red flag. Also, ongoing social networks of people who are either selling opioids or are not in treatment can be some of the aberrant behaviors. And if many of these things are going on, we want to monitor these patients closely, right? Urine drug screens should be done routinely. The spirit of urine drug screens is important. I tell my patients, I'm not doing it because I'm the sheriff, because I'm not. We're doing it so we can figure out what's going on and we can find the safest and most efficacious way of treating you, of meeting our shared goals. That's really the idea. Now, we've included, again, this is a slide from PCSS, a common practical strategy for urine drug screens, right? So first of all, anytime you write a prescription, test for a panel, point of care testing, which is cheap, readily available, timely results for a variety of substances, right? We don't always have to do confirmatory testing because confirmatory testing is expensive, right? Can take a lot of time. On the other hand, confirmatory testing is a lot more accurate. So I reserve confirmatory testing for, discrepancies, right? So if the urine result comes up positive for amphetamines, for example, the first thing I'll do is talk to the patient. Very often the patient will say, yes, doc, I used some meth. If that's the case, I don't need to necessarily send it for confirmatory. But if there is a discrepancy where the patient says, there is no way I've used, it must be a false positive, then sending it for confirmatory gives me useful clinical information. So that can be a practical strategy that balances the accuracy versus cost, timeliness, and patient-centered care. Randomly observed every now and again. We don't do it every time, but we do periodically do random observed urine drug screens. And some things that we do is, in the strips, they'll often have temperature monitoring or even things like measuring for how dilute the urine is, the color, etc. Making sure the patient isn't taking in a purse, for example, or a backpack into the bathroom, turning off running water, coloring toilet water can be very helpful. To eliminate or minimize the possibility of dilution. So just some practical strategies I included. And checking for buprenorphine metabolite. If I just add some buprenorphine into the urine, my urine will be positive for buprenorphine, but not for buprenorphine metabolite. So every now and again, sending that urine out for a buprenorphine metabolite is a good strategy. What we've done at our clinic is tied it in to our random callbacks, which is the next slide. So we do a random callbacks as part of the treatment agreement. All of our patients know that about every 3 or 4 months, they'll get a call from one of our MAs. We'll try calling them 3 times in a 24-hour period. Once they get the call, they've got 48 hours to come in with their remaining medication. When they come in, that's their random pill count. One of the nurses or MAs will sit down, make sure the count is accurate. That's when we get the random observed urine and also send it out for buprenorphine metabolite, right? So kind of a practical strategy. Doesn't have to happen all the time, but it is a good way to minimize diversion. And that's the random pill counts. Finally, how do you respond to it? I just want to take a minute or two to talk about it. I think it's all about balancing benefits and risks, right? And having a patient-centered discussion, shared decision-making, and proper documentation. If in doubt, bring up the case to our ECHO, and we can provide a consultation, and we can all work through together as a team to see how to best help this patient. Remember that it's not up to us, right, to determine if the patient is good or bad, or if the patient deserves the medications, should they be punished, rewarded. As providers, as clinicians, we don't do that. Our goal is, do the benefits of this treatment outweigh any side effects and risks or the harms to patient or society? And that's the discussion we should be having with our patients and documenting it. Manage it within the practitioner-patient relationship, right? Try to understand the patient's point of view, talk to the patient, and document. Be non-judgmental. If you notice some of these aberrant behaviors, generally the first thing we do is increase the frequency of visits, even if they're just brief check-ins with the nursing staff. Obtain collateral information, involve family, other providers, right? More frequent testing for UDS, smaller quantities of medication. Consider things like, now we have other options, the Sublocade, the injectable long-acting buprenorphine, or injectable long-acting Vivitrol, and naltrexone, right? Consider some of those options which are effective and don't really have diversion potential. So we reserve it really for patients who got aberrant behaviors and I'm unable to get those under control. And if they continue, if no other options are reasonable, considering a higher level of care, such as an opioid treatment program, or if you can find it, an IOP or a residential program. Document your reasoning, and really the cessation of treatment, stopping treatment, should be last resort. Right? Sometimes we have to do it. Sometimes we have to tell our patients, maybe you're not ready for this right now, and we can reevaluate when you are. But especially to stop it abruptly carries a lot of risk of relapse and even overdose. So we really reserve it, as a last resort only. So with that, I will stop here. I think we have time for maybe one question or so, and I'll